How are you today? I'm really psyched that you're back. It's nice to see you. I've got great show for you today. Shorty but a goodie. We're going to go over a viewer question about spinal fusion, a topic that's certainly near and dear to my heart, and I know many of yours as well. Very, very important thing for so many people. I also wanted to show you something kind of cool. This is Vive Organic Turmeric, 30,000 milligrams. It says mg, which I assume is milligrams, not micrograms. And the reason I think this is so cool is, remember when we talked about the need on an anti-inflammatory diet to use turmeric and ginger to not only keep your inflammation low, but to actively reduce it, that these guys have anti-inflammatory properties. Well, you know, tea is great and certainly is fresh, but you can only, it's hard to have tea at your desk during the day. If you're having a day where you're stiff or you feel a little under the weather or like you could use a boost, this looks like something you could try. Let me give it a shot. Yeah, that's the stuff. Remember how turmeric is, the absorption of turmeric is improved 10,000 times by pepper. it's, got, it's got a ton of black pepper. And I get that ginger is gonna be sweating it out for the rest of the day. Well, I wouldn't say it was a pleasant experience, but I think it was a really good one from an anti-inflammatory point of view. So I would recommend you try some of that, keep some of that handy. And hey, if you haven't seen those 5 steps videos in a while, go back and review our toast method for getting on or kind of bootstrapping your way into an anti-inflammatory diet. It's a very, very important issue. All right, let's hit the computer and go to our first slide so we can look at today's topic. Oh, they want to use my name. Not sure what's going on with this. Let's try that again. I'm in full screen mode. Very good. That's where I want to be. Let's see if I can. I don't know. I don't know. I'm going to give up on full screen mode and just go to partial screen mode, I guess. Well, this is a question that came in to us over YouTube from Mr. Chris D. And it was 4 days ago. Great information, Doc. Hey, thanks a lot, man. I appreciate that. I've had 9 lumbar surgeries and now fused from L2 to S1 after multiple revisions. Why is this continuing to happen? And how likely is it that more herniations, failed or upper spine areas will fail and require more surgery? Wow, 9 lumbar surgeries. Chris, you animal. I'm really sorry you've gone through all that. That's a very, very, just think about it, everybody. 9 times the mass coming down, going to sleep, waking up, the recovery pain, etc. And Chris, you're not alone. You know, I hear this a lot from people who've had spinal fusion surgery. And it's just noticeable. In fact, going into spinal fusion surgery, one of the concerns most people have is, well, aren't I just going to need fusion? It'll just creep up, 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 up. And the answer is, yeah, there is a very high rate of revision surgery, not only to the level that had surgery, but adjacent level surgery with spinal fusion. There's several reasons for that. Some of them are legit good reasons, and some of them, in my opinion, are just terrible, bad reasons. Some based literally on misunderstanding by some doctors of what's going on in your spine, and some based on your behavior, on patient behavior, and the desire to go from kind of acceptable to pain-free sometimes drives surgeons into areas where nobody should be. But we'll go through it: adjacent level dysfunction, what causes it, why it happens, and what you need to know about it in making good decisions. And in particular, Chris, I'm going to answer your question. What is the likelihood that you'll need additional surgery? And what are the risk factors for people having additional surgery? If you're somebody who, unlike Chris, He's fused from 2 to S1. But if you're somebody who's thinking about it, what would the things about you that might make it more likely that you're going to need adjacent level surgery compared to someone else who's not gonna? We're going to talk about all this and more today, right here on Best Practice Live. So let's get it going. All right, the first thing I want to talk to you about is, frankly, what is spinal fusion? Spinal fusion, what does that refer to? You hear that phrase all the time. And it's a little bit of a misnomer because spinal fusion is actually two things. One of them the surgeon does and the other one you do. Let's start out with the one that the surgeon does, because that will help us understand the one that you do. So here's a shorty model. This is a little spine, and here's this person facing you, and we've seen the discs and the vertebrae before, and each vertebrae bone is separated by a disc. And then if we turn them around, shorty, we've got the joints in the back. In a spinal fusion, the surgeon is going to fixate typically two structures. One is the joints, a facet joint on each side, and then the other is the disc. So the fusion starts out with fixation. Why is that? Well, if I break my bone and they put it in, if I break my arm and they put me in a cast and there's no movement of my arm bones, what's going to happen? Well, the bone is going to knit together. It's going to heal itself right back up. That's just normal for bone. That's what it does. It heals. That's its job. And the bone is, you think your bones are constant, but when you're growing and even in adult life, the bones are constantly being turned over and remodeled. And if, God forbid, something does break one, then it can heal itself and knit back together. But what about my joints? How come they don't knit together? Okay, if bone is constantly remodeling and healing, why do my finger joints still move? Why don't they fuse together? Well, they would if they didn't have cartilage separating the joints and if they weren't moving all the time. So when you're moving all the time, a little bone tries to knit a bridge across there, and because it moves, it doesn't happen. So that movement prevents the bone from fusing together. Same thing goes on in spinal fusion. By putting in pedicle screws, see this bone right here, this one that's vertical? This is the vertebral body, but this is the pedicle. The pedicle bone, if we put a screw through that bone here and another one here, and then we connected them with a rod and screwed it down, that would fixate so the joint couldn't move. And when it can't move, if the surgeon goes in and removes the cartilage, scratches it all out, that would cause, that fixation could lead to fusion. Same thing with the disc. If the screws are locking it in position and we take out the disc and put in a bone plug, now we've got bone on bone, and just like my broken arm, that can heal together and cause a spinal fusion. After you do your part, you don't get paid for it, right? The surgeon does, but you don't. But what you do is the more critical part and the permanent part. If you stopped when the surgeon was done and no additional growth occurred, no fusion would ever work, because everything man-made is temporary. And just, if you've ever taken a paper clip and worked at it like this, eventually the ductility of the metal, it'll crack. Well, the spinal fusion rods are much thicker, but they would actually do the same thing. If there was continued movement just through every day, bending and moving and shucking and jiving and doing your thing, then your rods would actually crack or your screws would break. But they don't, because where the surgeon took out the bone in the disc space and in the joint, you do a fusion. Your body goes on to heal it together like that fractured arm bone. There's nothing stopping it. The hardware is fixating it. So you go on to heal it together. And that's how that works. Fusion is a partnership between you and the surgeon. And the surgeon can screw it up, but usually not. I mean, what if you only had one job, right? The surgeon's an expert, and they're in there doing it with great instruments and great engineering. More often, what messes up the spinal fusion, or what causes it not to knit together, are things that happen on a person's end. If you're not super well nourished, you don't have enough protein in your diet, that can lead to a failure of fusion. If you're a smoker, there's less oxygen in your blood. Your bone needs that oxygen to heal, so less oxygen, less healing. That's a common cause of non-union. And there's, if something happens like there's an infection or something like that, all of those things can go together to cause non-union. But the vast majority of the time, it does fuse together and everything's okay. Now what? Well, spinal fusion is incredibly cool. It's very effective. It really, I've done thousands of spinal fusions back when I was a surgeon, and I can't think of an operation for which patients were more grateful, to be honest. And they're grateful because the pain goes away, the sciatica goes away, the shooting, if they had stenosis associated with the listhesis, that goes away. So spinal fusion is extremely effective. It's usually done because you've got scoliosis, those are deformities, or spondylolisthesis, that's a shift in the bones, or you were unstable because of an injury that you had, a fracture that left the bones that normally hold things together, unable to secure you properly. So of course, you don't want to damage those nerves inside the spinal canal, those nerve roots. So or even the spinal cord. So you got fixation and then went on to have fusion, and it's extremely effective. I mean, it's really kind of awesome. It's like having a dog that'll fetch you a beer. But what you find out over time is he was getting those beers from your neighbor's fridge. the spinal fusion is awesome at that level, but at the adjacent level, at the neighboring level, you now have, instead of that level absorbing all of its own shock and movement and stress and strain, all of that is now transmitted to the adjacent level. So the adjacent level has to work harder and is exposed to more force. And that more force at the adjacent level is a real problem. Well, you could study this, and we doctors have. Let me pull this back up. I want to show you guys something. I want to show you, let's take a look at this screen. This is a really interesting study from the International Journal of Orthopedics. This is back in 2019, which is 3 years ago, but it's pretty much the same information today. Adjacent segment degeneration after fusion spinal surgery, a systematic review. Remember, those are the 3 words we love to hear. A systematic review. Because we're not just talking about some single surgeon's experience. Remember our pyramid? So we're not talking about a little case control. We're not talking about even a randomized controlled trial, which is much better up the pyramid. But we're talking about a systematic review of all the information that's out there, where we're going to compile it together and really, really get to the bottom of what's going on. It's the top of the pyramid, ladies and gentlemen. Very cool. So that's where this article is. And the authors, Hashimoto and Aizawa, Kano, and Itoi, they go through all of the methodology that they used, but then they come up with an answer. And, quite frankly, this is the answer to the question that we were posed today. What is according to the meta-analysis, the pooled incidence of adjacent segment degeneration after lumbar fusion is 26.6%, almost 27%, David. So what is the probability that you're going to have additional segment degeneration? 27%. I can tell you from my own career and from the medical literature that the probability of having a spinal fusion is a repeat fusion within 5 years of a first fusion is 17% for every level. So that's a lot. That's a lot. And if you're thinking about having a spinal fusion because of a deformity or spondylolisthesis with stenosis, I mean, if you've had trauma and you're unstable, you don't have a choice, so you might as well not worry about it. But if you have a choice because of one of these degenerative conditions, you might want to think about that this is not one and done. This is not, I'll have it, and this is not the last surgery I'll ever have on my back in my life. No. There's a 17% chance that you're going to need another surgery as a result of this surgery. Okay, yeah, so there's what's that, an 83% chance that you're not, Okay, so much greater likelihood that you're not going to need another surgery. But if your attitude was, hey, I want to do one and done, I never want to have to face surgery again in my life, well, then don't have a spinal fusion, because that's not the case. There's a chance, it's relatively small, but there is a chance that you would need another surgeon. And you got to go into this stuff with your eyes wide open, understanding really what your risks are. Well, speaking of that, I mean, we know in medical conditions, sometimes some people are more likely than others to have a certain problem. And there's no blame, there's no shame in anything in being sick. That's not the issue. But the reality is there are certain features that you could have that make it more likely that you might actually need a spinal, that you might develop adjacent segment degeneration. And some of them are just obvious, like if the adjacent segment is already degenerated, duh, right? If there's already a problem there and now you're going to put more force on it, yeah, that's going to make it likely, more likely than if that adjacent level is 100% healthy and now you put more force on it, maybe it can accommodate it. But if it's already having problems, duh, it's more likely that it's gonna be a problem. Another one is weight. I think in medicine we often make too much of a risk factor out of weight, but you also can't deny that it's a risk. When you're putting more force on that hardware, you're transmitting increased force to the adjacent level, so that definitely makes sense. There's an element of genetics in this. I mean, we've talked about, I can't tell you exactly what the 9pq gene, chromosome is or whatever, but I can tell you that it runs in families, that people are predisposed to this kind of spinal degeneration. And so, yeah, the more you inherit your body phenotype from your parents. So if your parents were more prone to spine conditions, then you're going to be more prone, probably, or if one of your parents, you're going to be more prone to having an adjacent level issue. And nutrition definitely plays into it. If you're not getting adequate protein and all the rest, that can certainly be an issue. And then there's some things about the fusion which really make a big difference. So if you just have pedicle screws versus if you have the disc fused as well, what they call 360 fusion, circumferential fusion, there's some reports that increases the risk of adjacent level degeneration. Makes sense, right? Because by taking out all of the shock absorbers, the facet joints, as well as the disc, it seems like the less shock absorption you have, the more likely you would get an adjacent level problem. And then longer fusion segments. I mean, if you fuse L4 to L5, then all of that force is transmitted. But if you fuse L4 to L5 to S1, now you've got two levels where there's no adjacent shock absorption. And in David's case, we've got L2 fused to L3, fused to L4, fused to L5, fused to S1. So there are definitely risk factors that can go into this. And I would say actually the disposition of your surgeon is also a risk factor. Some surgeons are just have a low threshold to do surgery. So if you're not doing perfect, they may just recommend a reoperation. Or, in my mind, there's no evidence that non-union pseudoarthrosis is a painful condition. But a lot of surgeons, they see some incomplete bone growth, and they want to get back in there. Maybe you're having some pain, maybe it's not related to that, but now they're doing a second surgery causing more weakening of the ligaments and the muscles by exposing it again. So kind of the philosophy and the invasiveness of your surgeon can be an issue here. Are those surgeons wrong? No, they're just a different philosophy. Some people are more invasive in their approach than others. So obviously some surgeons are less invasive. Some surgeons see things in terms more of deformity. Some see it more in terms of isolated problems. I myself am a minimalist. I believe in minimally invasive surgery because I think it's safer, has fewer complications, and is just more elegant and gets you to solving the person's problem while causing fewer other problems. Not everybody sees it that way. And my old approach might have been right for one person, but it might have been wrong for another, and vice versa. Somebody else's more invasive approach might be right for one person and wrong for another. So you just got to kind of roll with the punches, but on the whole, go with the minimally invasive guys. They're safer and better and etc. Well, I think that's all I have got for you guys today. Let me check my notes real quick, make sure I didn't forget anything. Nope, that's it. I'll drop if you're curious and you want to see that paper, I'll drop the link in the comments. So go ahead and check that out. And don't forget, we're here to answer your questions online. So give us your questions. I'm dying to hear what's going on with you. I would love to find out what I can do to help. If I don't know the answer, I'll research it and get you one. The way you give us your questions is there's 3 ways you can call us, 602-256-2525. You can click through on the link here and go to our website, fill out a form where you input the question itself. That would be great. That's another way we can get the question. My staff are trained to take these off. You can also email us or chat, and we'll be happy to communicate with you. Sometimes we are going to ask you clarifying questions because we want to give you the best answer possible. Might want to, like, for example, one question we always ask is, well, do you have any imaging? Like that guy I saw yesterday, Harry. It was really a different story when I was able to see his imaging. I could give him a much better answer. If I can see your imaging, I might be able to give you a much better answer as well. So send us your questions. Have a great day and enjoy. I'll talk to you soon. For Best Practice Live, I'm Dr. Dan Lieberman. Have a good one.